a little over half of that were women and girls, which is going to be different than what you're going to see for our Shelby County area. But even, in the last few years, this has been great. At least 77% are accessing treatment, which is wonderful. And then again, if you look at most of our HIV, people living with HIV are in Eastern, Southern, Western, and Central Africa. As far as the United States, I'm going to be using slides, and I have the link for y'all when you get the slides later. This is called AIDS View, and we're going to be looking at it together. So I'll give you the link in a minute, but this is the map of the United States. You can see that the higher prevalence is heavily in the South. As far as our county, so Memphis is in Shelby County. And again, I'm going to remind you, prevalence is the number of people living with the disease. Incidence is new diagnoses per year. So they put it in more common language with new diagnosis rate, but that is incidence when you're thinking about that. So we have about 7,000 people living with HIV in Shelby County in 2023. And when you compare that to Tennessee, the South, and the United States, you can see that we have a disproportionate burden of infection in our area. Not just in prevalence, but also in incidence, so new diagnoses. I also want to look at the demographics. So this slide's kind of interesting because if you look at the gray bar, that's just percentage population of the population. So you can see increased burden when you see the darkened line extending past the gray line. That means that demographic group is disproportionately affected. And in Shelby County, our patients living with HIV and new incidents are disproportionately male and Black. And then when you look at the age, you're going to see the disproportion is mostly in the 25 to 34 and 35 to 44 for prevalence. But for incidence, unfortunately, it's younger. So it's 13 to 24 and 25 to 34 are the age groups that are acquiring HIV at a disproportionately fast rate in our county. All right, so let's talk a little bit about prevention. And again, even though we have wonderful treatments now that can be very effective against HIV infection, the best thing for patients would be to never acquire it in the first place. So one of the ways to prevent is HIV treatment. So if people are knowing their status, receive antiretroviral viral therapy, or ART, and get an undetectable viral load, they are then untransmittable. They cannot be pass the virus on to a partner. So really, I don't want to forget about this. It's really one of our mainstays of preventing HIV in our county and around the world. So the USPSTF gives recommendations for screening. You are all in medical world are very familiar with them, but we do tend to go by their recommendations. And there is a grade A recommendation for PrEP, which is the highest you can get. But it is not for everyone. It's not universal. They need to be at risk. So here is the risk factors. So if they have a partner who has HIV, they are at risk. If they've had a bacterial sexually transmitted infection, if they are a man who has sex with men, a transgendered woman, in the infections they get have to be in the past 6 months. But this third one here kind of opens the door a little bit. So it's really anyone who has a history of inconsistent or no condom use whose HIV status is unknown. So that really is what broadens, I think, the door to who might be eligible for PrEP, because it's really anyone who is having sex who's not using condoms and doesn't know their partner's status. We also give PrEP to people who are injecting drugs at this time or have a partner who are using IV drugs. Okay, so the other question, does it work? I have included at the back of this slide every study you could ever want about this, but I'm going to very quickly say the answer is yes. PrEP is very effective. It reduces the risk by about 99% when taken as prescribed. And there is some data lacking. We haven't done the studies in people with IV drug use, so we're not quite sure the exact, but it's at least 74% in what we can tell based on the data we have. And then it's also less effective if it's not taken as prescribed. Duh. So I could say that for about any medication I could give. And then this is the exciting part. Okay, the exciting part is I have many options for you. It used to be one, it brought into two. We were excited about the third in 2021, and now we have a fourth, and hopefully more. So I want to go over, there are two oral options. One is for anyone, and then the tenofovir alamide imcitabine is for not approved for women at this time. They're all once daily pills, and they are pretty much approved for everyone. You do need to monitor renal function and the tenofovir imcitabine arm. And then you also have different days to effectiveness. I always add that because I think it's interesting, especially if you're prescribing, you want to be able to tell people, similar to if you prescribed birth control, like when is this actually going to do what you're hoping it to do? So it is different for men versus women as far as rectal tissue and vaginal tissue. And then we all got super excited about injectable PrEP because so many people don't want to take a pill a day. And if you're thinking about that younger population, 13 to 23, how many, I don't have any of those patients that are like, you know what I want to take more pills. So this we thought would be great. I have plenty of high schoolers on, let's say, depot for birth control where they're coming in every 3 months. And I was like, this is the equivalent. This is safe. This is great. So cabotegravir became available in 2021. It does take time to figure out institutionally how to support this process. How do you get the medicine? How do you get it approved? Who gives it? How do you do the test in order to get it? And we'll talk more about that later. But it was great, but it's kind of a pain at times, to be honest with you. And it's every 2 months after you have your initial injections. And then I want to kind of highlight this is the exciting part for me anyways, and why I wanted to go back to PrEP, even though we've been doing it forever, is because this option that is now available for twice yearly, so every 6 month subcutaneous injections for PrEP, I think is a game changer. It's as close to a vaccine for HIV that we have. If you think about back when COVID came, we were supposed to get 2 vaccines, right, in a row? Not anymore, but then 2 vaccines a year. So we're very close to like an annual flu shot kind of thing can prevent HIV. And it was incredibly effective. And it was just approved in June. So that's what I really want. Not like you all have to just start doing that one, but it is changing the landscape of what we can do here at home as well as abroad as far as preventing HIV infections. So very excited about that. And then even, I'm not going to say more exciting, but also exciting, there are 2 phase 3 trials, so end-stage trials going on right now, which you can look at. One is Purpose 365, and that's investigating once yearly lenacapavir, so sort of like the flu booster shot I was talking about. It's just once a year. And then the second one is the Expressive trial, and this is a brand new pill, which is why it's called MK8527. I'm sure it will have a very long and hard to pronounce and terrible name soon. But for now, it's just letters and numbers, and it is a nucleoside reverse transcriptase translocation inhibitor. You're welcome. And what's great about this is it's a once monthly pill. So some people hate shots. To be able to take a pill once a month, that's incredible. That's incredible. So those studies are ongoing right now. And if you want to be like, I want to get my patients on this, if you follow these links, you can figure out where all the sites are. We do have one in Memphis that we're currently recruiting for as well. So very excited to come on the horizon. And then why do I get so excited about PrEP? Why do I care so much? Is when you go to AIDSview.org, which you can all start doing that because we're going to do that in a second for everybody on your devices, if you have them, or computers, you can see that our new diagnosis rate is just disproportionately male. And like we said, young. And so we're trying to get that PrEP to need ratio down. So the lower the number is, the more PrEP we need. The higher the number is for PrEP to need ratio, the better covered those patients are. So you can really see our lowest numbers are in our youngest patients. So that's why I think getting some of these newer options are going to be so much more palatable for that patient population. Okay, so this is the interactive part because we need to do lots of interaction. So this is just sort of a generic question. We're going to talk about it in a minute, but if you're not prescribing PrEP as part of your primary care practice, I always wonder, why not? I think, first of all, like, do you need to be? So that's where the AIDSview.org can help you. If you look it up, you can click to your exact county, find your own data. I would love for you to do that before you leave and just sort of see what is your need. Does anybody who's willing to say they're not prescribing PrEP want to talk about why not? Who's prescribing PrEP? Raise your hand so I can, hold on. Okay. Who wouldn't be allowed to prescribe PrEP? That's okay. So we got a few in there. Okay, so I'm gonna, since the room it's early and we're the first session, so we knew this might happen. So here we go. Your patients might be at risk. Find out, please. Because if they are and it's not a part of your practice and you can prescribe, I'd love for you to consider it or at least talk to me about how to get that done. Second, it has a grade A recommendation. If you are in medicine, I don't think there's many grade A recommendations you're allowed to ignore. So you should probably think about it, just like you do for diabetes screening, chlamydia and gonorrhea tests in women of a certain age, mammograms. It is effective, so that's great. So I went head-to-head on 2 trials because I'm always interested in number needed to treat, right? Like how much do we have to have out there to make a difference? And I don't remember the exact numbers now, but what I do remember is it was comparable or better than statins. So if statins are something you believe in and prescribe for cholesterol, for ASCVD risks, or prevent scores greater than, well, it's changing, so I don't want to say it, and then, the new guidelines are a bit confusing. You maybe should consider PrEP because it's just as effective as that. You don't have to treat that many people to make a difference. And for you who are providers, I think we're always worried that we're going to practice outside of our competence zone. And you might think, oh gosh, I can barely keep track of what I need to know. What about this? It's really easy to become competent. If you think about the other things you follow up with patients for, diabetes, heart failure, chronic kidney disease, hypertension, we're talking 2 orals, 2 injectables. That's 4 meds you need to figure out. There's good side effect profiles. These are quick, easy visits. So you tired of long, complicated visits about back pain? Do PrEP. They're in, they're out, they're healthy. Get yourself a template for the labs. You push one button and it's done. So I don't think it's easy to know what you're doing. It's also way less complicated than things you might already doing. I do a lot of birth control and I find that counseling to be a lot. And this is by far way easier. So there's sort of my pitch, at least to get you to consider. There are things these are the things that might be barriers for us as providers, but there's actually lots of barriers to the patients themselves for coming and seeking this kind of treatment, or for providers being able to have a welcoming environment. And that's what I want Dr. Moore to talk about kind of next.
So I have a question for you all. Considering the advancements made in HIV treatment and prevention, why do those negative perceptions still exist? What do you all think? Don't all speak at once. Go for it. Right. So she mentioned risk reduction and some people leaning more into abstinence. What else? What are some other reasons why those negative perceptions still exist? It could be generational, right? So some ideas about HIV and HIV prevention and what that may mean. That may differ, according to generations. Based on what you all are saying, it's stigma. Stigma is the reason why those negative perceptions still exist, even though we have all this great information that tells us differently. And we know that stigma are a set of negative attitudes that oftentimes come from misinformation that can sometimes lead to discrimination and shame. So when you all think about HIV or PrEP, what types of stigma have you heard of? What types of messaging have you all gotten? Go for it.
Like how infectious it is, like transmitted, things like that.
Right, so it's really infectious. HIV is so easy to transmit.
And how effective
It's It only affects men who have sex with men. Some other things. Y'all live in very progressive societies. Y'all hadn't heard anything bad. This is awesome. You can get it from testing someone. Oh, from kissing someone. Go for it.
I've heard a little bit of like stigma around IV drug use and people that share needles and stuff like that.
Absolutely, stigma around IV drug use and the sharing of needles.
I'm a pharmacist, and one of our newer pharmacy technicians, we have a program where people can have their HIV meds and other things sent to our clinic to pick up. And he asked if he needed to wear gloves to handle the bag and the HIV meds were in. Just as an example of some methadone. So
Absolutely. A lot of that fear-based stigma. So a lot of the things that you all were talking about were like stigmas of moral judgment. Like, okay, if I'm, working with people, maybe I shouldn't tell them to use PrEP. Maybe I should just tell them to abstain from sex. Go for it.
I've had people with PrEP thinking that like, oh, well, I only need PrEP if I'm going to or something. And I'm like, oh.
Right.
Then, okay, let's have a discussion about that.
Absolutely. It's only necessary if I'm risky. Uh-huh.
This is more of a practical, it's not really a stigma, but I work in a secular FQHC, and there's just, we have so much else to deal with. People think HIV care, that's someone else. That's like a family planning clinic. Like I'm dealing with the diabetes, the hypertension. The reality is like also doing PrEP feels like too much. And so people just ignore it. They don't talk about STDs and pregnancy and stuff like that because they're focused on the chronic. I think that's reality in a lot of, it's not about even the stigma of the disease, it's just the practicality, what do I have time for it? So you just don't do it.
Express it out. Yeah, so this doesn't pertain to me. It takes too much time and I have to focus on something that's equally as important, but more important here. Absolutely. All of these different types of stigma exist. And because of that, we see people who are afraid to even go in and know their status. We have people who feel uncomfortable even being around a person who may have HIV. Even though we all know that we can't see it. It doesn't have a face, it doesn't have a look. And research in 2024 suggests that if you live in the South, then there are higher incidents of this level of discomfort surrounding HIV. And why is that an issue? Well, it's an issue because the higher number of rates of HIV tend to exist within the southern region of the United States. In 2024, it was about 52% of all HIV cases were from people in the South. And so that's a really big problem because if people have this negative perception of HIV prevention, HIV care, they're less likely to go in and get treated, or they're less likely to go in and take measures to not contract the virus in the first place. And that's when we have these different PrEP-related stigma. And so sometimes it could be, there's some medical mistrust. Sometimes, especially in certain regions and with certain cultural groups, people feel like, they're saying that this thing can prevent me from, contracting HIV. Well, they also said this thing in Tuskegee many years ago, but then they ended up giving a whole community of people syphilis. So there might be some medical mistrust there. So it's really important that we provide messaging that talk about the benefits of PrEP and then show that it can be beneficial for all people. And even as healthcare providers, sometimes we have our own biases. I know at one point, when I first started my PhD program, I was doing research with women living in HIV in the Mid-South. And I was young, I didn't know much, but I know that when I walked into those focus groups, I too felt uncomfortable. I was like, oh my goodness, what if I'm, having a conversation with one of these women? What if some saliva gets in my eye? Am I at risk? So I felt afraid to the point where I was like, I don't know if I want to participate in this research. And I had to be prayerful, I had to be introspective, and I had to seek some research of my own to understand that I was safe. And then I also had to get out of my own way and recognize this is another person in front of me. This is a human being with a very interesting story that I can learn from and then help to share this information with others. But that stigma exists. And I could imagine if 20-something-year-old Kanisha felt that way, I could imagine other people may as well. There are also some different cultural and contextual factors that people have to consider. Sometimes people's religious beliefs will get in the way of them going in and doing this proactive act. So they may say, well, no, if I go and I start using PrEP, then I'm giving myself permission to engage in premarital sex. Not necessarily true, but sometimes that's the messaging that people may tell themselves. There are also different socio-demographic factors, those peer discussions, and some psychosocial factors that come into play too that prevent people from going in and even being interested in learning about PrEP. Sometimes what people talk about within their peer groups is just the sharing of a lot of misinformation, so much misinformation, and then people walk around with these negative perceptions about things. And so the major issue with PrEP stigma is that if stigma is high, then initiation and adherence will be low. And in spaces, especially in the South, where we know incidence of HIV is high, that's a major problem because it's something that could absolutely be prevented. So what can we do to help address that stigma? Well, there are a few behavioral strategies that I think are important to implement to help address that stigma within ourselves and within the people that we work with. One of the first things that we can do is reduce provider bias to improve patient trust. So there are different trainings that are available to help providers get a better understanding of PrEP and even find ways to be introspective to kind of challenge their own ideas and beliefs so that when they are working with people, they don't feel biased or they're not judgmental towards those people, and they can provide them with some really great counseling to help them make a decision for their own future. We can combine some provider training, community education, peer support, and individual counseling to reduce stigma. We can also challenge those cultural norms. So let me ask you all a question. How many of y'all have seen that commercial for PrEP on the TV? I was about to say the internet. When we think about the people in those PrEP commercials, do they feel inclusive? Do they include all kinds of people? Not necessarily. Most of the ones that I've seen, they don't tell you, this is a man who sleeps with men. They don't say that, but they have certain gestures that kind of, give you that idea, right? Well, if we could challenge those cultural norms, if we could change the image of the people who would benefit from PrEP, that would also help to reduce some of that stigma. If we can support marginalized populations to improve access and equity. Oftentimes, when people think about HIV-related care, they don't want to be sought out. They don't want the finger pointed at them. They don't want people to know, oh, this person is going in because they have an incurable virus that they can spread to other people. And so one of the things that you all can offer, especially as primary care providers, is offer it in primary care clinics. Feel comfortable enough to prescribe. And now I'm not a prescribing doctor, that's not my jam. But if that's something that you do, being willing to offer that and have those conversations when people are coming in for a sinus infection. If they're coming in because, my sinuses are acting up really bad, that's great. And have you also heard of this thing if you believe that they're a person who would benefit from it? We can leverage peers and social networks to normalize discussions. If you all look at social media today, there are conversations about all kinds of things. We have podcast bros and sisters talking about everything under the sun. Well, if we could have some public conversations about the benefit of PrEP, that would also really help to reduce that stigma. We can empower individuals to psychologically reduce internalized stigma and increase their own confidence. And if you work in behavioral health, you can really help to challenge some cognitions that people have. Sometimes our own beliefs really impact the way that we think, which impacts how we feel, which impacts the decisions that we make. And if we can talk to people to understand why they think the way that they think and challenge that thinking when it gets in the way of what they actually want or what would actually benefit them, that would be helpful. And then we can have continuous evaluation to monitor stigma reduction over time. Groupthink is a real thing. And if people believe that everyone is okay with it, if it becomes normalized and people recognize that it's normalized, then more people would also begin to normalize it for themselves, and we can reduce stigma. So if we continue to monitor the decrease in stigma and we're vocal about it, we make it visible so that people can see it. Those are also some really great ways to help reduce stigma. So my question for you all, are you all prepared to address PrEP-related stigma? Yes, that's what I was hoping y'all would say. Are you prepared to reduce PrEP-related stigma? Yes, very good. Thank you all, thank you all. And I get it. Sometimes the work that we do can interfere with our own beliefs. And sometimes we feel like, I don't want to make it like I'm saying it's okay to engage in certain activities that, my moral or religious beliefs don't support. Sometimes that can be really difficult. However, we also have an additional challenge that can really help us to get over that idea. Dr. Milman.
Thank you, Dr. Moore. All right, so I've given lots of medical talks about PrEP in my role, and I don't often get to talk about this piece, and I think this is the right venue for that. And what I want to say is, I don't have the answer for you, but I want to think about it together, okay? So prescribing PrEP and acting honorably. I was reminded of this verse in Hebrews that says, pray for us, which, yes, please. For we are sure we have a clear conscience, desiring to act honorably in all things. So I want you to know that if you are questioning prescribing PrEP and how that interfaces with your beliefs, good. And nobody's going to judge you here for that. If you love PrEP and you want to put it on a billboard and think it's the best thing since sliced bread, good. We're here to support you in that. But if you haven't thought about it yet and you're beginning to, I don't know if you've ever learned about anything in training and then it wasn't until later you thought, wait, what do I really think about that? We want to open that space here a little bit, not forever, for you all to think about where you are. And each of us can share where we're at, where we are prescribing PrEP, and I'd be happy to say more, but I more want to give you a framework for you to think about it for yourself as you're praying, reading scripture, and trying to think about it. And I think one of the biggest things, like we talked about, is ideally, people would be doing things that are healthy and integrated with who they are and their bodies, right? And we know that a lot of the riskier behavior that we discuss that makes people eligible for PrEP or leads to HIV infection is not fully healthy for your body, nor potentially part of your spiritual journey in a way that can impact that. So we know that. But I want to say here that even when you put Christianity aside, even the medical community agrees that no one should prescribe PrEP as a pill. It comes as a package with risk avoidance and risk reduction counseling. It is the mainstay. And I put up the one that they put on the CDC here, but it's basically saying these are key components of behavioral risk reduction counseling. It talks about eliciting barriers to that, reducing substance abuse, using condoms. What steps can they take to get towards risk reduction? So I want to say that while we're talking about PrEP today, you can't have one without the other. So it is the expectation in the medical community, not just the Christian community, that we're talking about behavior and risk reduction and doing that in a way that decreases stigma and provides people with a safe space to get care, if that makes sense. I also looked at the Catholic Medical Association. I have many dear brothers and sisters in Christ who are Catholic. And again, Catholicism itself is very clear, right? It does not condone extramarital sex. It does not condone using condoms for birth control. It's very cut and dry. But this is the Catholic Medical Association. So the association then's like, what do we do where we can integrate our medical knowledge and care with our Catholic belief system? And so they do have a position statement, which you're welcome to read in full. I pulled out an important part that says it's sort of a both and, right? They affirm that prevention is a worthy goal of medicine consistent with its moral tradition, but specifically prevention of STIs are not intrinsically evil. However, not all means to prevent disease are morally illicit. So again, there's some discussion there. There are other people thinking about this that you can kind of go to and use. And then I think a lot of people say, does prescribing PrEP encourage immoral behavior? If people are like, woohoo, the one thing holding me back was my risk of getting HIV and I don't have that anymore. And so yay, now I can go and do whatever I want. And, this is a logical concern, right? Because you're thinking if people are scared and avoid risky behavior, then we remove that risk. Are we supporting unhealthy behaviors? So do we have data on that? And the answer is we do. There may be more data later. Things always change. But right now, what they found is it actually may increase safer sex practices. And I think it's because of the combination of care. If you're getting those risk reduction strategies, if you're speaking to our lovely behavioral health team and thinking about the why behind your behavior, and if you're taking ownership and feel more confidence in yourself and your health care, maybe you say no when you could have said yes in another situation. So the IPREX study was actually about PrEP effectiveness, but what they did find is that people, again, they were testing, but people who believed they were on PrEP had fewer receptive anal sex partners, syphilis incidence decreased, and condom use increased. Again, having this as part of the package seems to actually go against what we might logically assume. It does actually decrease risky behavior that we know, what we know. Again, we haven't studied everything everywhere. All right, so just other things to consider or contemplate for yourself. So again, I highly encourage you when you have questions to not just research the medical literature. Please do that. Please, know what you're talking about. But also, have you prayed about it? Have you prayed alone, seen what God wants you to do? Have you prayed in community with people that you trust? This isn't something that should be secret. We should all pray about it together, right? Also, would prescribing PrEP compromise your integrity? And I think of this as consistency in practice. Integrity means you're the same person no matter what. So if any of these listed things are things that you've come to the conclusion you don't do, you may want to reconsider prescribing PrEP. So, for example, do you prescribe erectile dysfunction medication to unmarried men? If you don't, on principle, okay, that kind of puts you in a category you might want to think about it. Do you prescribe birth control to unmarried women? Do you recommend condom use? But I also say this is sort of a flip side of a coin, right? So if you do those things I mentioned, then potentially prescribing PrEP is actually consistent with your practice goals and beliefs. Again, do be aware we have many, not biblical Christian values, but cultural Christian values. We are learning that time and way right now. But are you falling into the worst sin trap, meaning that you're happy prescribing GLP-1 to people suffering from gluttony, but you're not going to prescribe PrEP for people who are trying not to acquire HIV? Be careful, right? Careful. And then the judgmental trap, these people you might think don't look like me, aren't like me, aren't doing things I would do. And so I'm going to stick to my diabetes and hypertension and back pain, which is more universal. Again, think about it. Or they're young people and you're not young anymore. I'm finding that more and more where I'm just like, what are y'all doing? So again, just think about, are you just, sort of judging? And then this is, if I had to put into some words, where I come from, it'd be this last one. Are you committed to advocating for improving the health of all your patients and community and agree that acquiring HIV should be off the table if the possibility of prevention exists? So again, is it acceptable to prevent a disease when it exists? And we can go back to why the stigma isn't true, right? A good fourth of our patients are women. They're not men having sex with men. Worldwide, that's certainly not the case. So again, think, pray, talk to people about it. Don't be afraid. And we'd love to talk more about it. So I'm going to pause just quick for questions. I know that this could there'd be a lot of good discussion, but hold on, where are we at? We're doing great. We do have a little worksheet we want y'all to work on later, but I'm happy to take some questions now. If anything resonated with you or you have more questions that I didn't think about, I'm sure there are many. We would love to hear people's thoughts. Yes. Oh, yeah. Yeah.
If the highest that you're seeing in the population where you're seeing is those younger, as young as 13 into the mid-20s. My question is that actually more attractive? Is that more sex work? What is it that is bringing that age true? Because I feel like that would be different in their stigma and how we're responding to patients.
Correct.
In there, right? Because if
Mm-hmm.
you test for HIV and admitting that it's not a killer, like it's a very different conversation, you know?
Correct. So her question was, if your population happens to be significantly younger, then you might be looking at things like trafficking or stigma related to if you admit you want testing or you need PrEP. That means you have a handler or they're actually controlling what you're doing. So how would that change, or what would you think? And I think that they haven't really sparsed it out by age differently. Obviously, if you think of a 13, 14-year-old acquiring HIV, you feel that some type of abuse has to be involved, right? And we do see that, and I think you should be very careful about not assuming that somebody's making the choice to have sex, but that they might not have the choice to have sex. And I find that some of those routine screeners and things that we ask can be so helpful in giving you a clue about that. So pay attention to other risky behaviors, other things going on. The fact that it's not a parent in the room with them. I think there are ways that you're going to say, like, you definitely need this medication, and here's how and why. And then obviously under 13, each state is different. We have to report. And then if we thought a child was being abused at any age, we report. So reporting may become part of your system. That doesn't mean you don't do PrEP, but obviously you would hope to be able to move towards removing a minor from that situation. We do see, though, that as we talked about normalization, so sexual experimenting and experimenting of all types has become normalized for a lot of our teens. And I can't tell you the number of times I see where, I don't mean one and done, but basically you're like, yay, I'm going to go out there. But the statistics in Memphis is, particularly if you're a black male looking to have a relationship with another black male, every sexual encounter you have a 50% chance, flip a coin, of acquiring HIV in Shelby County. So imagine you're a young black man and you're doing what all your other peers are doing and you've been told is normal. You're going to flip a coin, whether or not you now have HIV or not. So again, I think that you don't, like Dr. Moore said, HIV doesn't have a face. So this is something that you universally screen behaviors for. And when you do that, you find out. Yeah.
I know that there are a lot of like programs, like government programs, like public health departments, where getting like medication for HIV, it comes at no cost or significantly reduced. What are you finding for like insurance coverage for PrEP to be preventative? And a lot of times insurance coverage is very less likely.
Great.
The cost for getting.
Great question. So the question was about the cost of medication and if insurances are sort of coming on board. And the answer is fortunately yes. So insurances definitely, because it's a grade A USPSTF, I think I got that right, a recommendation, they have to cover it in a lot of ways. There's even codes to remind them they have to cover it. And there's copay programs and things like that. So getting coverage is a pain, but is there. For uninsured programs, you're looking at the companies that produce them. So Gilead has a program. Truvada is now generic. So anybody can get it at one of our pharmacies for about $9 for a month. So the cost has really come down, and I do think they are cost effective, whether you have bad insurance, Medicaid, good insurance, or no insurance. All right, the sign went up, so we have to move on. All right, this is your part. We will stand together, but okay, so we're going to look at your system. I don't know your environment. I want you to think about your environment, and I want you to think about teamwork in your environment, because I promise you, I don't care how awesome you are, you will need help to implement PrEP in your system. It usually involves a team. So I want you guys to think about a couple different things. I have them on your papers in front of you. If you didn't get one, there's some extra ones in the front where nobody wanted to sit, so just pass them back to whoever in the back needs them. So you want to think about your patient population. Think about providers. What do the providers need to be able to prescribe PrEP? What about your nursing and other support staff? You're not doing this alone. You're not giving the injection, probably. So what about them? Let's talk about behavioral health and social work and case managers. What other supports? What do you have in place already? Who could be doing these? How could you get them? Obviously, you need pharmacy or maybe medication storage if you're talking about injectables. There's laboratory issues. How do you get your labs done? How would you make that happen easily? Do you have a template with your EMR? Do you have rapid HIV tests? Which ones are you using? Which ones are cheaper? How would you find out? Insurance and prior authorizations, boo. But they have to happen. Follow-up visits. How do you get them back in? Because this isn't one and done, right? They're not suddenly at risk and then not at risk. How do you track who you're seeing so you can like promote it and make it more normal? And then is there funding available? We have this Ending the HIV Epidemic federal initiative. Do you have money that is available to you through that? So again, I want you guys to get in groups of about, it looks like 2 or 3 would be good. I want you to share your experiences. If those of you who raised your hands and said you are prescribing PEP, what areas, it's a SWOT analysis, sorry. But what are your strengths? What are your weaknesses? What are some opportunities? And if you have the Whova app, you can go, there's 10 more slides that kind of ask some questions about each of these. So if you know, wow, we're really short on nursing staff, you might want to pop down to the nursing staff and look at some of those questions. So go ahead and meet up together, share each other's experiences. What kind of social supports do you have in place? Where could you get more? Who's going to do what? And then again, we'll kind of pop through this. And then just in case, I think that'll take the rest of our time. At the last slide, which again is available, we have provider training opportunities. And then there's behavioral health training opportunities. If you're like, man, Dr. Moore did such a good job, and I really want to fight stigma more. That was one slide. Tell me more. This is where we recommend y'all go. Do you have anything to add before? Say go.
And I just highlighted under the HIV Prevention Certified Provider Program that Module 4 is what talks about reducing stigma, because there are several modules and it takes a little time. But this information will be available to you all on Whova.
All right, get in your groups, please. Make some friends.
All right, everyone. Thank you all so very much. Thank you all so very much for coming and witnessing our presentation today. We are incredibly grateful. Before we leave, I wanted to give a couple shout outs to some people from Christ Community who are here. I mentioned my manager, Dr. Samples, who is the chair of behavioral health. We also have Dr. Green, who is our chief medical officer. And we have Dr. Andrews there in the purple shirt, and he is our director of special populations and clinical training. That was a long title. I had to make sure I got that one right. Thank you all so much for supporting us and being here. If you all have any questions for us, please feel free to put them in the Whova app, and we will do our very best to answer them. Thank you all again for coming out and supporting us. We hope you have an incredible day and an amazing time at the conference. Thank you. Should I tell them to scan this QR code?
I think they're on it, but I'll say it. I see most of you doing it, but this QR code will go to our survey. Please fill it out so that we can know ways to make things even more awesome next year. Oh, and if you look, you're going to get my PowerPoint should be connected, but also you're going to see a bunch of attachments. Those are basically the prep training materials I use for providers. And so I just included them in case anybody's going home thinking I need something to jumpstart. So I just put out what's in my little folder of what I share with new providers. It's in, I don't know. How are we saying it, folks? Whova. Whova. It's in Whova. Great, thanks. And I think it's lunch, right, before the plenary at 1 p.m. Please don't miss the first plenary. It's always dynamic and awesome.